Okay. Let's just double check and make sure everything is sounding good. And then after we do that, we will be off to the races, folks. What races? I don't even know, but that's just the euphemism, I guess, that people say. All right, I think everything's good on the YouTube side of things. So if everything's good on the YouTube side of things, just let me share this real quick on Twitter and we will get rocking and also rolling and see how it goes. You know? Okay, I think we're good. I think everything here is good. Let's just share it real quick and off to the races. Okay. So it's been shared. We're up and running. We're good to go. Whoa, Jonathan Cogburn is here. It's too cold for podcasts, he says. Wow. Well, you let me know if this podcast doesn't warm your heart a little bit. Maybe it'll help. You know what I mean? So you just let me know, Jonathan. Well, good afternoon, good morning, good evening, whoever you are, wherever you are. Thank you so much for showing up. This is episode 52 of UnShrink Me. And for those of you who don't know, UnShrink Me is a weekly podcast that I put out on my YouTube channel with the specific emphasis on educating the public, generally speaking, the consumers of mental health services about what are and what are not quality standards, what is valid and what is not valid from the point of view of science, and all these kinds of things. So our goal in the UnShrink Me universe is just to criticize what's not helpful and talk about what is actually helpful for patients, both from the point of view of science, my clinical experience, the people I know, the people here in the chat like Jonathan and Jake. So thank you both for being here. And, generally this is just to educate the public and inform people about what I believe in a real, honest, unfiltered way, what actually is helpful, and criticize the bullshit that is guru stuff online on Instagram and Twitter, and just not actually helpful, but just serves therapists more than actually serves patients. So that's the spirit of this podcast. Thank you so much for being here. There's some discussion currently about the weather because apparently other places that are not California are really going through it, but I am trapped here in Southern California where the weather is very nice and warm and sunny outside, but apparently people are being basically bludgeoned by cold weather, which I can't even imagine what that's like here. So God bless all of you who are currently going through it in other parts of the country. So today, and as always, we are not NOT sponsored by Celsius, but this stuff is great and I absolutely love it. So today we have much to discuss, and the kind of three main topics is what precisely gives us as clinicians authority. So Nick Tabor is someone I've been talking to and talking about on Twitter about this topic. So I think it'd be good to talk more about that so that people who are seeking out therapy understand why and in what ways clinicians actually have authority and the ways in which we do not have authority. The second topic is, what can we generally call mental health? But third, and I think that this third topic is perhaps maybe more important to some degree, but I could be wrong about this, is are you broken? And if so, why is that? So that's what's on the agenda today, and let's see what's going on in the chat here. I see some shenanigans. And apparently there are weather complaints. 7 degrees in Montana, Jake says. This is prime podcasting weather. This is absolutely prime podcasting weather. The colder it is, the better time it is to be inside and taking care of yourself, obviously. Jonathan says the Texas mind cannot comprehend. Exactly. So first and foremost, let's start with the post Let's start with the softball because starting with a softball is easier. So I'll retweet this real quick while I'm talking and rambling here. So Dr. James Davies, who has sometimes made an appearance because of his tweets and posts, put out a banger earlier today that I would like to discuss. So I'm going to retweet it right now and just say I'm discussing this on the podcast right now. Okay. And if you don't know what I'm tweeting about and discussing, please follow me on Twitter, X, whatever, at Alobha Patrick, at ALOBHAPATRICK, which means non-attachment Patrick. So I just posted it. So Dr. James Davies, said, educating young people to be resilient, in quotes, to the effects of deep social/structural injustices and inequalities is literally becoming a flagship neoliberal policy, rendering the next generation tolerant of a rigged economy that acts against their health, flourishing, and happiness. So there's just so much that is being discussed in this post of his, so let's talk about what this tweet's about. So first part of it is educating young people to be resilient, in quotes, to the effects of deep social structural injustices and inequalities is literally becoming a flagship neoliberal policy, rendering the next generation tolerant of a rigged economy that acts against their health. So basically, he's complaining about the idea, he's criticizing, discussing the idea that encouraging people to be resilient means they're tolerating things that should be intolerable. So my rebuttal to Dr. Davies, and this is just, me being a silly clinical psychologist, is it better for people to be fragile and flimsy when they feel overwhelmed and pissed off about what is an injustice in the world? Like, is it better that people fall apart emotionally? Is that really good for people's mental health to just fall apart when they see how shitty the world is? Because, objectively, there are parts of the world and there are parts of society that are objectively shitty. Objectively. Not subjectively, but all people would agree certain parts of society are shitty. And it's not even a question. So just to name two particular examples from his tweet, economic and structural issues. So it's absolutely the case that in the United States of America, certain parts of our economy are rigged against the poor and rigged against the undereducated and rigged against the personality differences. So people who are extroverted tend to do better in this economy than people who are introverted. So there's many objective facts. But should the people who are not privileged or favorable just fall to pieces every time they look at how stupid the economic structure is and how rigged it is that the most productive thing to do, is to fall apart all the time and bitch and complain on Twitter? Probably not. It's totally fine to have a social critique. I think that's very valuable. But in the spirit of mental health, I can't imagine as a clinical psychologist encouraging people to fall apart because they're justified. Just to name a tangential but related example, if I have a patient with PTSD, I'm not going to gently encourage them to have a flashback. That doesn't seem productive to me. However, if they happen to have a flashback, I will ask them what would they like to do with this feeling of overwhelm and hypervigilance and anger and rage and whatever comes along with their flashback. I would like to, in an informed consent way, ask them what they would like to do. And most people I've worked with clinically just call me a crazy person for thinking this, but it's been pretty consistent in my life that the people that I've worked with would like to become more resilient to the harsh realities and absurdities of existence. Most people I've worked with, because they've tried the opposite, which is falling apart and being a mess, and it doesn't seem to work for them. Their life seems to get worse the less resilient they are. So, dear Dr. Davies, can you point me in the direction of a reasonable, effective way of functioning in a rigged system that's good for people? Is it good for people to whine? Is it good for people to have panic attacks and to have mental breakdowns? Is that the best choice? Because in my profession, I've never seen anyone encourage that. My buddy Career Flex is here. He also says some of my best friends are riggers. Are you a rigger, Career Flex? Are you an oil rigger? Is that what you're saying? Anyways, so dear Dr. Davies, I I understand that it's true that in the United States of America, many facets of the economy, of the political structure, the legal structure, are rigged against the general population's health, flourishing, and happiness, as you said. I agree with you. I think I am 100% in agreement with you. I would never say anything else. I believe that this country is run by oligarchs and all that stuff, which has nothing to do with mental health. And the truth of the matter is that we have choices. So this is where I probably sound less popular to some people. And that's okay. If you don't like it, Phil's here. Good to see you, Phil. But like generally, I would like for people to live the best possible life despite their circumstances. So that sentence is really tricky because despite their circumstances means that the circumstances could be objectively good, bad, or a mix, right? And so what does it mean to live a good life despite the circumstances? It means to choose to have agency, which is the opposite of falling apart. Falling apart doesn't seem particularly productive from what I can tell. But maybe that makes me a bad, bigoted right-winger or left-winger or whatever. I don't know. Career Flex says, recently in grad school, the whole concept of resilience was considered to be an evidence of privilege, which is bullshit, by the way. I teach in graduate psychology, and no one in my department is like, resilience is bad, right? He said, which is absurd. Which is absurd. Like, helping people learn to not just tolerate things that are bad for us, but learn how to overcome them is precisely what I think good clinical work does. Like all the evidence-based modalities that help people with PTSD, for instance. For those of you who don't know, there are a number of evidence-based treatments that can help people with PTSD. For instance, there's EMDR. There's also prolonged exposure therapy. There's cognitive processing therapy. There are different types of psychodynamic things that people can do with people with PTSD. There are a host of things we can do to help people with PTSD. And all of them share a couple of things in common, which include understanding what's happening to you while you're having the symptoms of PTSD, acknowledging them and accepting them, but also learning how to have agency despite the symptoms. So when people like Dr. Davies say this crap, it seems to me that they don't want people to have agency. They want people to fall apart and whine and complain and feel bad and live in their feelings as opposed to having productive solutions for those feelings. And as a clinical psychologist, I think having productive solutions for feelings is part of my job description. But what would I know? Anyways, Darren McGee says, good evening, everyone. Good to see you, Darren. So glad that you're here. Drew says, I've never understood how explaining to individuals that they have agency is a bad thing. Me too, Drew. Me too. I can't imagine the opposite. Let's all walk out the opposite example. Let's talk about this. So let's imagine the opposite. Let's imagine the opposite example was the thing that was recommended, which is you don't have agency. You are pathetic and helpless. What would the consequence of that be? Likely, now this is just a fantasy. It's a theoretical, so forgive me. But in theory, if we were to, as professionals, tell people that they are helpless and pathetic and they have no agency, probably what that would do is that would encourage them to do less, try less, and give up. And I don't know that giving up is ethical. I don't know that that's something that the literature says is helpful. So from the point of view of so-called science, I can't imagine that that strategy would work. I'm not sure which evidence-based treatment says give up. Is it CBT? Is it DBT? Is it ACT? Is it EMDR? Is it cognitive processing therapy? Which one of these therapies that we're supposed to be using says give up? I don't see that. What I see is we're supposed to engage in an attitude of acceptance and then develop agency, despite how bad we feel, despite how tortured we are by our illnesses. Drew says something very important, so I'm going to highlight this and expand because Drew said something amazing, which is hope is a huge common factor for treatment. So let me say this clearly. If you don't have hope, nothing is going to work. If you don't believe that the thing you're doing is going to work for you, guess what's not going to work, right? Expectancy is a technical word for that. So if you have no expectancy or weak expectancy, then of course it's not going to work. So that's hope. Career Flex says it's cultural Marxism. I don't know that it's even that. I think it's just stupidity. I think it's just cowardice. I think it's just people who are terrified of fighting the good fight for themselves and other people. They would rather whine and talk about injustice as opposed to doing something, right? But because I am optimistic, I believe that the vast majority of people, despite their circumstances, can live better lives. I believe society sucks in so many ways, but I believe that individual people and small communities of people can do amazing things. This is what I was saying last week, is how dare anyone talk down to people and say, you are not capable. How rude, how demeaning, how hopelessness-inducing, how learned helplessness-inducing of you to say you are not capable of living a better life. That's crap. That's absurd bullshit, because everyone is capable of living a better life, and I've directly witnessed it and been part of it as a professional for almost 20 years in my life. So screw everyone who thinks that you are not capable of living a better life, despite your circumstances. Many people have horrific circumstances and overcome them, and I get to observe it every week of my life. So just a quick, nice and easy starter. Thank you, Dr. Davies, for the grist for the mill. All right. So, formal topic number 1, which is a contentious topic. So I want to do this thoughtfully and reasonably. So Nick Tabor, who I've retweeted and posted about many times, has this ongoing contention with the mental health community and the profession generally. And the contention is this, and it's a perfectly valid contention. So the contention is this: on what basis do therapists, psychiatrists, etc., have any authority to talk about the individual and have an objective opinion about the subjective experiences of individuals? So I want to walk this out for everyone. Nick Tabor, I think, and Nick, if you watch this, let me see if I can find his post here, because I think it's a good one. On what basis? Yeah, I can't find it, Nick. But like, on what basis? Drew says, now we're cooking. On what basis? Darren said, that's not therapy. When you're trying to disempower people, that's control. Yeah, I don't want to control anyone. The last thing I want to do as a professional, as a professor, as a consultant, as a couples therapist or family therapist or whatever, I don't want to control anyone. That's the last thing I want, because the more control I have, the more it's on me, and I don't want shit to be on me. Honestly, I don't want to have any responsibility for someone else's life. I can barely handle my own life. I mean, look at me. Like, I could barely take care of myself. Can you imagine me trying to take care of somebody else and be responsible for somebody else? That's absurd. So what I would say is, it's impossible. And this goes to the next point about authority and where do therapists get authority, right? People like Nick Tabor, I think, misunderstand what our job actually is. Now, if you've been abused by the system, which Nick admittedly openly states he has been, so if you've been traumatized or abused by the system, you will have a distorted view of what we're actually here to do. And I'm not saying he's wrong. He's actually right about a lot of things. So I'm not saying this is all just his trauma and projection. I'm not saying that at all. I'm not trying to dismiss Nick. I'm saying that I think he has at least a 50% distorted view of what clinicians are here to do. And so I'd like to actually walk out the reason clinicians have any authority whatsoever. So the only reason, in my opinion, clinicians have any authority, and this might be controversial, right? But just go with me. And if you don't agree, I'd love to hear about it in the chat. But the only reason therapists have any authority is because of informed consent. I'm going to say that again. the only reason, in my opinion, I could be wrong. I have colleagues who disagree with me, but this is my opinion as just Patrick, who's been in the profession before the profession, has people, family members in the profession. I know dozens and dozens and dozens of people in the profession. And so I'm sampling people all over the world from all sorts of backgrounds, genders, sexualities, cultures, religions, all sorts of things. And so my opinion, kind of trying to integrate all the things I've experienced in my life and just understanding who I am as a person and how different I am too, I believe that the only reason clinicians have any authority is the concept of informed consent. And what I mean by that specifically is there's a legal definition of informed consent, which is clinicians are supposed to describe as clearly and understandably to the patient as possible what we believe we're here to do, what we believe will help, and how it will help, and ask the patient if they have any questions about what we're here to do, if we think it'll help, and how it will help, etc. And it's more than that too. It's about the laws and confidentiality and all these things. But generally speaking, I believe clinicians have only have authority because we have informed consent. And what I mean by this is we have explicitly told the patient what we believe will help, why we believe it will help, in a very limited, not like wasting thousands of hours explaining, but like why we believe we can help, what we believe will help, what our role is as the professional, what your role is as the patient. And that's it, right? So the only reason I believe clinicians have any authority is not because of the science of psychotherapy. I don't believe that's a great argument at all. It's not because of the ethics of psychotherapy. I think our ethics code is flimsy at best. The American Psychological Association's Code of Ethics or whatever is great in a general way, but it doesn't actually address specific problems across all facets of what could be harm or not harm. But it's a really good start in many ways. All right, the 5 principles, beneficence, non-maleficence, all that stuff, that's all great. I think that's all great. So I genuinely believe that the only reason that clinicians have any authority is when we actually do informed consent correctly, where we are explicitly discussing what we believe is happening, what is our hypothesis about your suffering that you have described to us, why we understand it, how we understand it, what we believe could help, why we believe it could help, what our role is as clinicians, what your role is as patients. Those 5 things I just said, that is the only basis of our authority. Because what that does is it limits what we are here to do as professionals. And that's it. So the best therapists are the ones who are extremely clear about the limits of what they're there to do. The best therapists are not the ones who believe they have an answer for everything, that they're here to fix every problem, etc. The best therapists are the ones who know how limited their scope is. Those are the best clinicians. They have a clearly defined problem that the patient agrees is actually the problem. It's not me, brilliant professor Dr. Lockwood, brilliant psychologist, who says this is the problem. It is the patient saying 30 minutes of this, that, and the other, and then we get to go, okay, I think I heard you say this. Is that correct? So we have no authority except for what the patient agrees is our authority. If you don't agree, then we don't have that authority. That is my take. Informed consent is the only thing that gives us authority. My degree gives me 0 authority. My knowledge about the brain, which is a lot, by the way. My knowledge about psychopharmacology, because I teach it for the graduate level. That's a lot. I know a lot about evolutionary psychology. I know a fair amount about cognitive psychology. I know something about philosophy. I know about a lot of different things. And I can use these concepts fairly fluidly in a way that I think is useful. That being said, all this crap that I know is useless unless the patient thinks it's useful. So for me, my authority is only limited to what the patient thinks my authority should be. And it's my job ethically as a clinician, it's every clinician's job ethically to describe in crystal clear terms that you understand and the patient understands what they think the problem is and what you think the problem is. And if you don't agree, then you don't do a thing until you both agree. That's ethical informed consent. Darren McGee says it's collaborative. Of course it's collaborative. If it's not collaborative, you're not doing clinical work. You're being a dictator. And there are lots, by the way, for those of you who don't know, there are many, many, many professionals, MD, PhD, PsyD, MA, MFT, whatever, people of all degrees who are not clinicians. They're gurus, which means they're dictators. Guru is a polite word for dictator. I'm going to say that again. Guru is a polite word for dictator. So there are many people in the profession who are not clinicians. They're just gurus. There are many people in the profession who are not clinicians. They're just voyeurs. Some people in the profession are literally just voyeurs. They just want to watch you suffer and like help you, but really they just want to keep being on the roller coaster with you. So there's so much pathology in the profession that I believe informed consent is not done correctly and ethically all the time, right? So I agree, Nick Tabor, and everyone else who is critical of therapy and psychology and psychiatry, that informed consent is rarely done correctly. And so on what basis do any of us have any authority is a great question. I would say so many people have zero authority because they've done no informed consent. So a couple of people have spoken up here in the chat. So I want to speak to that. So Phil says, alcoholism is self-diagnosed. Absolutely, right? Because it's not even really a diagnosis. Alcoholism is it's a colloquial term. It's a term of art that people in a shared self-help meeting like AA have for themselves. It's not a formal diagnosis, right? It's a concept that it may or may not be helpful for you and your loved ones, right? Drew says, that's a great definition. Probably more dictators in the helping professions than I thought before getting into the field. Absolutely. Me too. Like when I was in graduate school, I thought everyone was like, yeah, this is collaborative. Everyone's going to do the ethical thing because we don't want to hurt people, right? Because like we want to help people. We don't want to hurt people, right? But the truth is there's a lot of hurting people and helping people in our profession. And it's not because people mostly intentionally want to hurt people. It's because they unintentionally want to hurt people. They narcissistically believe they're helping when they're hurting, etc. So again, to reiterate, the spirit of this conversation is many people online are very, very, very critical of the profession. Jonathan says dictator, as in DICK-TATER. Absolutely. Sorry, everyone else was being serious, so I had to go a different way. Yeah, it should always be funny. I mean, it's absurd that we're even talking about this, Jonathan, so appreciate it. So like this, like the anti-psychiatry and anti-mental health people, the Scientologists and the Nick Tabors and everyone in between, right? So for all the people who think mental health treatment is bullshit, for all the people who think therapy doesn't work, for all the people who think there's no such thing as ethical treatment, I genuinely believe that you're onto something because you're correct that people use bad research. So one of Nick Tabor's criticisms is that there's not a good scientific grounding for most mental health concepts. Correct in many ways, wrong in other ways. And so, yes, appeals to authority, appeals to science, all these things are incorrect ways of looking at what mental health is, how therapy works and doesn't work. So the only authority that mental health professionals actually have is informed consent. And if anyone disagrees, I would love to know on what basis you disagree. I mean this 100% seriously. For all of you in the chat, for all of you who are watching and listening, for all of you who watch this after the fact, I would love for you to comment. I would love for you to share this with people you know who are either in therapy or not in therapy or in the profession. I want to hear about this because I believe this is like one of the most groundbreaking things I'll ever say in my career, which is We only have authority so long as patients give us authority because we've done our job ethically in terms of informed consent. That's it. It's not because we are magically smarter, magically brilliant, magically self-aware. No therapist is magically smarter, magically brilliant, magically self-aware, magically insightful, magically ethical, magically boundaried. None of us are. We are all regular people, which means we all have baggage. All of our shit shows up in therapy, which means that we are people. And because of that, we have to be extra mindful because we are being paid to do a specific job to support other people in a way that they choose for us to support them. It's a lot of words to say ethical informed consent. Ethical informed consent is the only basis of authority that clinicians ever have. We have no authority for any other reason. We don't have authority because of the science of it all. We don't have authority because of our training. We don't have authority because of our jacket. We don't have authority for any of those reasons. Darren McGee says, in some instances, guru can be a polite term for twat. I completely agree. Yes. Completely agree. Yeah. Noman is here in the chat and asked a really good question. Let's see if we can walk it out. So here's what Noman said. And by the way, thanks for chatting, by the way. I don't think I've seen you here before. He said, what's the difference between a therapist and a clinical psychologist? Do they have different authority? No. So the only real difference is clinical psychologists, if they have a PhD or PsyD, etc., clinical psychologists have special training to do certain types of intellectual assessment, personality assessment, and things like that. However, most therapists have the same capacity ethically and legally to do different types of therapy, be it individual, family, and couples therapy, group therapy, consultation, and testing, and expert witnesses, and all that stuff. So clinical psychologists are a type of therapist because of the type of degree that they have and a type of training that they have. But most therapists, people with a master's degree or even a doctorate degree of different kinds, have similar capacities and skills. Now, to be fair, folks with a PhD or PsyD have more education, more years of education, maybe or maybe not more quality education, but usually that means they have more years of supervised training before they get licensed as well. So, yeah, I hope that answers the question well. I don't know at 7AJAJJ. What if a patient is sectioned? What is a sectioned patient? Can you explain what you mean by sectioned? I don't know what that means. Jonathan Cogburn says, I agree, Patrick. If we're ethical and informed consent, we'll have been clear, that there's no magic and that an underlying purpose is to enhance client agency to support maintenance of change post-care. Exactly. There is no magic. Therapists who tell you they have a magic treatment, ACT, CBT, DBT, EMDR, CPT, whatever, there's no magic. None of it's magic. None of it's rocket science. None of it's super complicated. Most people could learn to do these things to themselves without ever needing a therapist. That being said, it's an ethical relationship. It's a boundaried relationship. It's informed consent that makes clinical work so different and important. Oh, at 7AJ says detained, UK term for forcing patient to go to psychiatric hospital. So what if a patient is forced to go to a psychiatric hospital? So at 7AJ, whoever you are, I don't know the laws in the UK, so I can't speak to you. Do you have a particular question about what is helpful, not helpful? Like, what exactly is your question specifically? Could you be more specific? Noman says, I don't understand the difference between a therapist and psychologist. Yeah. So therapist is a general term. It's a very broad term. It's an umbrella term for anyone who does the practice and art of psychotherapy. So people with a master's degree, people with a PhD or MD, etc., can do therapy. A clinical psychologist is a person with a doctorate degree, a PhD or a PsyD, who does therapy, testing, assessment, and all this stuff. So it's a term specifically for people with a doctorate degree. Oh, okay. So at 7AJ says, how does being forced to go to a psychiatric hospital change the concept of authority? It doesn't, right? So there's a difference between having like literal ethical authority versus legal power, right? So I'm not using authority in this context to mean power, right? One of the things that happens to Nick Tabor and I when I talk about this online is I think we get our antennae crossed. I think we get our lines crossed because I think people like him are interested in the legal authority of people. And I'm talking about the clinical or medical authority, like the practical reality of authority. And he's talking about legal things. So legally, when you're forced on a psychiatric hold here in the state of California, you have access to a court-appointed representative who can fight on your behalf to either, shorten your stay, lengthen your stay, et cetera, based upon how well you're doing. So you have representation, essentially. But we have laws specifically in the state of California about being gravely disabled, harm to self or other people that dictate whether or not you can be legally put on a psychiatric hold. And so I don't know if the laws are different in the UK or how different they are. I'm not aware. So I would say that from the point of view of California, at least, it's a question, the legal authority question has nothing to do with what clinicians are good at determining. That's the problem. And so people like Nick are pissed because legally you can get away with terrible things if you can view the symptoms of the person, the behaviors of the person as symptoms. But whether or not the behaviors of the person are symptoms is a clinical judgment call. But when it comes to the legal authority to put someone in a psychiatric hospital, that's got nothing to do with a clinical authority when I'm talking about with informed consent. There is zero informed consent when you're put on a hold. Now, once you get into the hospital, if people are ethical in the hospital, they will state that I believe you should be on these meds in order to become less of a risk of harm to self or others. What happens in psych hospitals often is you are given no choice. You are to take these meds or else, which is not ethical in the sense of like it's not morally ethical, right? But that's a clinical judgment. Is this person so at risk of killing themselves or other people that we should quote unquote force them to take these medications, coerce them through argument or physical force, restraint? And so for me, I think that's tragic. I always tell my students this. I did a year of training in a psych hospital. And only one time in that whole time was I one of like 5 people that had to hold somebody down while they were being injected with something to sedate them. And I don't know what it was like for that individual, and I can only imagine what it was like for that individual. But what I will tell you is that is one of the most dehumanizing things I've ever participated in my life. And it's one of the reasons why I don't work in psych hospitals, because I do not want to participate in anything that's dehumanizing. That being said, that person that was being injected against their will was threatening to harm themselves in a way that could have killed themselves. So the truth of the matter is we're in a very weird ethical place, which is, what exactly is the limit? Does it matter if they're about to die? Does it matter if they're about to kill somebody else? Who is making the judgment they're about to die? How certain can we be that they're about to die or that they're about to kill somebody else? That's very gray, and I don't have a good scientific answer. Jardom says, if I could super chat for asking this question, I would. I don't know how to super chat. Maybe I should get better at this. I don't know. Maybe I should turn on something like super chat. I don't know. I don't think I'm famous enough or popular enough on YouTube to have super chats. Maybe I should get more famous. Can you all help me get more subscribers so I can super chat? Jardom says, if I could super chat for asking this question, I would. What does one do when the NHS mental health team says they can't help you? That's a phenomenal question. And I don't have a good answer for you because it's very situation specific. So ethically speaking, I obviously can't comment as a professional on that question. What I can say is there are different types of things that ethical clinicians could say to you. So for instance, one thing that's really important, that's very, very important is if a clinician, if a psychiatrist or psychologist or therapist or whatever says they cannot help you, that means there are probably other types of considerations that need to be addressed. So for instance, I've worked with some people that I know I can't help because their drug use is too severe. So like I have a tiny private practice. It's a boutique thing that I don't advertise, but like other than this statement, but like, and there are people that have tried to come to see me, but I can't work with them because their drug use is so bad that they would show up to my office intoxicated, and I can't work with someone who's intoxicated. So it's like, that's a problem that can be addressed somewhere else. I can't address that. I don't have the skills. I don't have the structure or the resources to address that. Right. Yeah. So like, it really depends upon what are the reasons why they can't help you, Jardom. Like, why can't they help you? Did they say specifically why they can't help you? Because depending upon what their answer is, that will dictate what the truth actually is of what you might want to address in other ways, if it's medical or social or something of that nature. There's a cat down here. At 7AJ says, oh, yeah, that may all make sense. Thanks. I get the distinction between your ethics and the legal powers. Yeah, ethics and the law have nothing to do with each other, unfortunately. Now, some, at least in the United States, some states will choose to take your ethics code and use that language in their laws around the practice of psychology. So the state of California has taken some of the language from the APA and from the other master's level ethics codes and incorporated that into their legal jargon. But for the most part, ethics and law are separate but tangential, if that makes sense. So I'm only interested in what I can ethically and legally do, right? CareerFlex has a question. I don't know if this is going to be a good answer to the question. So this is a loaded question, but it's a good one. CareerFlex says, Doc, how do we get the asylums back open in the U.S.? That's a good question. So that's a very loaded question because the implication is we need more asylums. And I think that a lot of people in the profession very much agree that we need more psychiatric hospitals. And what I would say is yes and no, right? So in some regions of the country, we certainly need more psychiatric hospitals. In other regions of the country, we need more residential treatment centers. Now, here in California, we don't need more of anything, to be fair. But in other parts of the country, there's not enough residential programs that are ethical, right? So for the places that need more psychiatric hospitals, you need to find people with money and with talent who are willing to do that ethically. That's the simple answer. You know, so like if I was willing to sell my soul a little bit and someone gave me $1 billion, I would open up, this is just like a wild theoretical. So if there's billionaires out there who want to give me some money, here's what I would do with your money to make you some more money. There's two things I would do if I was handed $1 billion. The first thing I would do is I would go to states that don't have enough residential treatment and find a way to open up one good residential program in each of those states. Places that have no emergency psychiatric care, I would open up psychiatric emergency outpatient urgent cares, right? So as opposed to psych hospitals, I would open up psychiatric urgent cares, right? So if someone could give me $1 billion, I would go open up a bunch of psychiatric urgent cares because the urgent care model is better than the psych hospital model, personally. So if you want to make a bunch of money, go open up a bunch of psychiatric urgent cares. Find doctors who are good at that. Noman says, so how does therapy fix people? Do you like manipulate them into doing better? That's what I heard. Yeah, Noman has a great question. How does therapy fix people? So, Noman, thank you so much for asking this question. I'm going to get to your question, but first I want to get to a couple more of the comments. So at 7AJ says, back to Jardam, he says, they should at least give you a vague rationale for rejecting the referral. Absolutely. They should always tell you why I can't help you. I always tell people, if I can't work with them, why I can't work with them. It could be time. It could be energy. It could be I'm not a specialist in that. It could be so many things, right? Yeah. Megan Shea says, make asylums great again, make them happen again. Let's not abuse people. Let's actually help them, right? Psychiatric urgent cares is the way of the future, in my opinion. Anyways, so let's go back to Noman's question. Noman's question, and Willow's here, by the way. See this? See this right here? Look at this. Look at this. You see this? Do you see this? Look at this thing. Look at this beautiful thing. Anyways, so the question Noman asked, which is really important, which leads to the second half, or another one of my questions and prompts from today, is the broken Rolex fallacy. So Noman, if you haven't heard me say this, I've tweeted about it before, but here's a full-length explanation. Noman asked, how does therapy fix people? Do you manipulate them into doing better? Great question. So, first and foremost, therapy does not fix people. Therapy cannot fix people because people are not broken. So that's point number one. Excuse me. So, people are not broken because when you view people as things, only things can break. Right? So a bone is a thing and a bone breaks. A computer is a thing and a computer breaks, right? But anyone, including fucking Elon Musk and everyone else who thinks they're geniuses, who call the brain a computer are retarded. It's not true. It's literally not true. The brain is not a computer. It doesn't even function like a computer. It's in no way like a computer. People talk about circuits in neuroscience, but they don't mean literal circuits like you have in computers because they don't function the same way. So the brain is not a computer. And this is what leads to what I call the broken Rolex fallacy. When people come to psychiatry and psychology, they come to rehabs, they come to therapists, and they're like, my son is broken, send him off to rehab. My daughter is broken, they have an addiction, send him off to rehab. Fix him, bring him back to me. That's the broken Rolex fallacy, which is you are broken, you can be shipped off somewhere, you can be fixed, and you can be brought back perfect and shiny and brand new. And that is how so many people think about mental health, the brain, etc. But it's wrong. Like, if you ever want to watch someone repair a Rolex, go to Instagram or whatever you have, and there's some amazing videos of people taking 50-year-old Rolexes that are broken with broken glass and scratches and stuff, and they ship them off to Switzerland. They get taken apart meticulously, and they get replaced and fixed and repaired meticulously, and it's amazing to watch. And then they look brand new when they're done, and that's a miracle, and it's awesome. And the Rolex is a very valuable, precious watch, right? So when people think of their child or their husband or whatever as broken, it's like, here's this beautiful broken Rolex. It's this beautiful, precious person to me that I want to go get fixed and get back. But people aren't things. The mind isn't a thing. The mind is an ecosystem, right? The mind is an ecosystem. The mind is not a computer. And when you think of the mind as a computer, of course you're going to think you can fix a broken input. I'm going to fix your broken amygdala, and then your PTSD is going to disappear, which is bullshit. You can't fix a broken amygdala. That doesn't happen. You can certainly take an electrode, shove it in someone's brain, stimulate a piece of the amygdala, and then their behavior happens. But that doesn't mean that that circuit that was stimulated operates that way at all times in every way, shape, and form, because there are hundreds, if not thousands, of inputs to any particular circuit, which means there's great variability. Right? Just like an ecosystem has thousands of inputs: sun, water, wind, clouds, dirt, fungi, animals. Like this, look at this. Look at this creature right here. Can you all see this creature? Can you all see this? Here, look at this. Look at this creature. Look at this creature. You see this? See this right here? This animal contributes to the ecosystem, right? And so it's the ecosystem that matters. And the mind is an ecosystem. And when you view the mind as an ecosystem with lots of inputs, lots of outputs, with dynamics and weather and climate and all these things, then you have the correct metaphor. So, dear Noman, you can't fix people in therapy because there's nothing to fix. That's an outdated view of looking at how people work. But secondarily, when you view the mind as an ecosystem, how does therapy help is a very complicated question to answer. Because for some people, when they come to therapy, what helps them is just having a safe place to unwind. Other people come to therapy and they want to look at their erroneous beliefs, their beliefs that aren't accurate, and change them. Other people come to therapy because they feel overwhelmed and they don't know how to regulate themselves. So there's so many ways that people come to therapy, and there's so many ways we can help ethically. So you had a second question, which is, do you manipulate them into doing better? Yes. But that goes back to informed consent. So as opposed to the word manipulate, I would say collaborate. Because as an ethical therapist, I never do the magician's thing. So what magician therapists do is they do a vague bullshit version of informed consent, and then they do manipulate you. They do a bunch of stuff that you can't understand. But ethical therapists should be telling you, this is what I'm going to do, this is what I'm going to talk about with you, these are the interventions I want to try, and this is why. So if you're in therapy and you don't understand what your therapist is doing with you and why they're doing it with you, then that person is a magician, not a therapist, and they are manipulating you. But as an ethical clinician, when I supervise interns and try to help them get better at clinical skills, I'm trying to help them become better collaborators, not gods and gurus who manipulate you. Because that's crap. That's not being a clinician. That's being a guru. And screw those people. Jonathan responded to Noman, helping the patient break loose from repeating patterns. Absolutely. Helping the patient break loose. We're not breaking them loose a bit. We're not magically powerful, right? Once they begin to become unstuck, then it's how do we support them on their journey to stay unstuck? Megan says urgent care is a great idea. Absolutely. Jonathan said, Patrick said system. So the drinking game, the Celsius drinking game we have here is every time I say system, we take a drink. So yeah. So Noman says, what's the point of therapy then? I didn't know there were unethical doctors in therapy. I thought they were all trained to do good or going to school because they are good. No way. No way, Noman. Dearest Noman, let me explain this to you very simply. And I don't mean this in an arrogant way. I mean this in this is a shitty thing I have to say. The vast majority of people who come into graduate psychology are not super healthy. They're mostly not super healthy. That being said, with really good mentors, good professors, good clinical supervisors, I try to be a good clinical supervisor. I don't know if I am, but I try really hard to tell the truth, to be honest about what's wrong with me, what's going on with me, what's going on with other people, what I believe I know, what I don't know. I try really hard. That doesn't mean I always succeed, but I try. However, a lot of people come into this profession, the profession of therapy, clinical psychology, because they want to control people, manipulate people, be a guru, fix their own stuff by trying to help people. There's a lot of really unhealthy people in the profession. And most graduate programs have a basic curriculum that helps them figure out what doing good is. But most people need really good supervision and training, probably their own work, to figure out what it means to actually do good. So I hope that helps, Noman. I'm not trying to be pessimistic. I'm trying to be optimistic because it's not super complicated what I'm describing. Noman says, how do you get the bad ones out? Do you stop them from going into their career? Well, there's a couple of ways to screen out people who are less qualified, right? So on the graduate end, on the graduate school side of things, we have admissions criteria. Some of those criteria include, certain limitations from their personal stuff, how they interact in the interviews, things like that. Their intellect, their skills, their capabilities, their track record, all these things. We have some metrics and standards that I think are decent, which I can't share publicly. But then the other thing we can do is we can see how you respond in a pressured situation, right? So in most graduate psychology training, you have to actually start doing practicum. You have to start doing clinical work under the supervision of either one of your professors or someone else. And that's your first test of if you can actually do the work. And some people are screened out in the first or second year based upon that. So there are layers of screening. Then you have to pass your licensure exam. Then you have to pass your ethics exam and all these things. And so there are layers of accountability and obstacles for you to actually become a licensed clinician. And depending upon the type of degree you get, there are more or less layers because there's more or less training, fewer years, etc. So broken Rolex fallacy. You are not a thing. Your brain is not a computer. That's crap. It's not true. It's fundamentally not true. The brain is an ecosystem. The mind is an ecosystem. And when we treat the brain like a thing, we get bad results. People don't get better. People have less optimal lives. When we treat the brain like an ecosystem, when we look at all the interacting dynamics and layers and people and things and places and physical health and all the things, people tend to make incremental progress towards their mental health goals. Incremental progress is the way to go. Okay. So this has been, I think, a really productive chat. I really appreciate you all being here. We've had lots of views, lots of comments today. I really appreciate this. This is awesome. And I want to reiterate what I said at the top of this, which is the specific topic of on what basis do clinicians have authority? I want to hear from as many people as possible. Excuse me. So if you could please share this video with as many people in the profession or people who have received therapy before, I'd love to hear everyone's response to that. Because my take, and I'd love to hear all criticisms of my take is the only way, the one and only way that clinicians have any authority is because of informed consent done ethically, where clinicians do 5 things. They describe in detail what, hypothetically, it's a hypothesis, we believe the problem is based on what the patient has said. And if the patient doesn't agree with what we are saying, then number 1's done. We have to go back to the drawing board. But number 1, hypothesis, what's the problem? Number 2, what do we think could possibly help? Number 3, why? In what ways could it possibly help? Number 4, what is my responsibility as the professional? Ethically, legally, my role, what do I do? Number 5, what is your role as the patient? Those 5 things. Based upon those 5 things, do we have any authority? And if the hypothesis is not correct, then the rest of those 4 things don't matter. We have to go back to the drawing board. So, informed consent, ethical, correct, accurate, informed consent is the only authority we have. We have no scientific authority. We don't have professional competency authority. I don't believe in any of that. As a professor in graduate psychology, I believe that I'm here to teach people ideas and concepts that are probably helpful across different types of situations. But I don't believe I have special magical authority just because I get to be a professor. Just because I get to be a clinical psychologist or a consultant or a family therapist. I don't have special magical authority because I am not special and I am not magical. My coat is magical. My cat is magical. But I am not, right? And so, I know I'm being absurd, but like it's informed consent. And if anyone disagrees, I want to understand why you disagree. And if you think there's a better version of authority that we have, I don't think we have anything else, personally. So thank you all for being here. Please like, share, and subscribe. Please help me build a following so I can get some super chats, maybe even make a little money or something. Who knows? So thank you all for being here. And as always, if you're brand new to the show, I like to end with a therapy joke. And so without further delay, here we go. So I once had this patient. Very confusing case. And this patient said to me, Dr. Lockwood, I am terrified of numbers. And there are lots of different types of phobias. Some I've heard of, most I've heard of, some I have not heard of. And this was the first that I met someone with a phobia of numbers. So anyways, doing my first session with the person, I just, ask all the standard open-ended questions. When did this start? How did it start? What happens? What caused it, do you think? How is it harming your life? All these things. So by the end of the first session, the intake session, this person explains to me that their phobia of numbers is really about the fact that when they were in middle school, they had a math teacher, and the math teacher was really mean, talked down to them, told them they were stupid. They were basically shamed and at least mildly traumatized by the experience because they thought that they were never going to be successful in school, they're never going to have a successful life and all this stuff. And so basically this phobia, this fear of thinking about or talking about numbers really comes from what happened in math class. And so, as you can imagine, checks out. So at the end of the first session, the patient looks at me and says, well, do you think you can help me? Do you think we can work together? Do you think my story makes sense? I said, yeah, that all adds up. All right. Good to see you all. See you all next week. Take good care of each other. Take good care of yourself. Most importantly, have good food, have good sex, and take good care of everyone you know and love.